Hi, everybody. This is another episode of We Are M&R, and we're real excited today to welcome to our episode here. We've got doctors Erin and Jason Carnes that are joining us today, and they've uh, been real generous with their time on a Sunday and are going to join us and kind of share some of their expertise on this situation because there's a lot of questions. Unfortunately, there's also a lot of misinformation. So we thought it'd be really helpful to have a chance to talk to some pros that are out there in the field, seeing what's going on.
I'm an internal medicine physician, so I practice outpatient primary care internal medicine for a group called Medical Partners. It's a physician-owned practice in the greater Charlotte area in North Carolina. Um, you know, only do outpatient medicine, only take care of adults, and so we do a little bit of preventative medicine and then chronic disease management as well.
And I'm Erin Carnes, and I am actually board certified in emergency medicine. I did primarily ER work for several years, but now I primarily work in hospice and palliative care for a company called Hospice of Iredell County. So I primarily see folks with chronic illnesses in their home. I also go into assisted livings and skilled nursing homes to see patients there. We do have an outpatient clinic as well as an inpatient unit as well. My typical day before all of this started, I would typically see anywhere between 6 to 10 patients in a day. I usually see those patients at home or in a skilled nursing or assisted living facility. I do sometimes see clinic patients and patients in our inpatient unit. So my typical day would usually look like I would go into the office, get whatever paperwork we have done, and then go out and see my patients in their homes, and then come back home at the end of the day. That has drastically changed after all of this, and it seems like it's an ever-evolving process because things are changing so quickly. So we're trying to adjust as best we can to meet the needs of our patients while also, trying to maintain our safety and their safety. So now what my day looks like is trying to do as many visits as I can via telemedicine, which I know a lot of practices are doing. We've been very fortunate that we're able to see a lot of our patients via telemedicine or using the telephone. There are some of my patients that are not able to do that, so I do still make some home visits. And just trying to make sure that we're using the right protective equipment, making sure we're screening those patients as best as we can for fever, cough, having family members in and out of the home that have traveled so that we can wear the gowns and masks and gloves and those types of things if we need to. But it changes every day.
And before all this, my day was somewhat similar. I would see between 18 to 20 patients per day. Was a mix of just well visits and well physicals. Some were chronic disease management visits, taking care of diabetes, heart disease, high blood pressure, and some sick visits as well from all different sorts of things, joint pains, colds, flus, stomach aches, those sorts of things. And the same, we've had to make an adjustment, some out of necessity and some, just from guidance from the CDC, where we're also doing a lot of virtual visits, which is very similar to what we're doing right now. Actually, in the office now, I probably am seeing between 3 and 5 patients actually in the office per day. Our group cares for about 130,000 people. We're the largest private internal medicine group in the Charlotte area, and we have multiple offices. And so, what we're doing is seeing only physicals, but even the physicals are being pre-screened to make sure that they're not having symptoms of the COVID-19. All the rest of our visits are done via virtual visit, and we actually, because we do care for so many individuals, have the capabilities of testing for coronavirus or the COVID-19, which a lot of independent practices don't have. It's mostly hospital systems that are doing the testing, but since we care for so many, we have these virtual visits that we can do. And if we feel like someone is potentially at risk, we actually have two off-site testing locations. These drive-through tests, which I'm sure people have seen on the news. It's again some recommendation from the CDC. And so patients that we're concerned that have respiratory symptoms, we'll send them to those sites, and then the physicians, nurse practitioners, nurses, et cetera, can actually evaluate the patient right there in their car. They just roll the window down, and they'll come over to your car and do a brief exam that way, and if needed, can perform testing that way as well. Differences now is we're actually expanding our day. So instead of the usual 8 to 5 day like our practice would generally have Monday through Friday, we have extended hours until about 8 p.m. Monday through Friday for virtual visits, and then we're also taking turns working on Saturday and Sunday from 9 a.m. to 2 p.m. doing virtual visits so that we can reduce the burden for the hospitals and the emergency rooms for patients that have concerns regarding coronavirus.
I think that everywhere, medical practices, hospitals, where we are trying very hard to prepare, but it's difficult because the anticipated numbers of patients that are going to need to be hospitalized is just more than there are beds available. The number of patients who will need ventilators, at least our prediction for that, it is just much, much greater than the actual number of ventilators that are here. So I know from an inpatient standpoint, we have lots of friends who work in the hospitals and in the ERs, and they're trying very, very hard to get more ventilators, get more supplies. We've been very fortunate where we are that a lot of local companies have really shifted over their production to making things that we can use, things like shields for patients that need to be intubated, donating things like masks. I know both of our organizations have received donations from both individuals and local companies who have helped us to have the protective equipment that we need. But there is definitely still a shortage. I mean, these masks that we wear are designed to be one-time use, and we're not able to do that. So while I think there is a real effort to try to make sure we're prepared, I think we still have a long ways to go. It is challenging. It's challenging for a lot of reasons because our lives are very different than what they were 3 weeks ago. So there is the challenge of doctor, mom, and dad trying to, change everything that we've done at work to learn a new platform, to try to meet the needs of our patients, and then coming home and trying to meet the needs of our family and also keep everybody well. So the kids are being homeschooled now, which is its own challenge. So we, typically speaking, are trying to get up. We wear scrubs to work because they're easily cleaned and sanitized. And we come home and immediately go change. The scrubs go into the wash on a sanitized cycle so that we're keeping clean. We scrub up. I am wearing my hair back all the time so that I can keep germs away. All of our medical equipment stays either in the car or at the office, even though we're cleaning it very frequently just to try to minimize the germs we bring into our home. And we really aren't seeing anyone else. So that includes, unfortunately, other family members. It's just our family staying home, socially distancing ourselves. I know that everybody hears a lot about that, but that's really the best way that we can protect ourselves and our family. And it's hard because we do have 3 beautiful and also rambunctious kids. So trying to keep them happy and entertained and safe at the same time. What you can't see in the background is they're like dancing around while we're trying to do this. So it's challenging, I think, for a lot of reasons.
Yeah, it's very difficult because the symptoms overlap with so many other respiratory illnesses. Fever by far and away is the number one symptom, but cough and shortness of breath are also extremely common, seen in the vast majority of patients. But some patients exhibit different symptoms. We're learning more and more that loss of the sense of smell and sense of taste seems to be seen with this virus, particularly early on. So, a lot of the hospital systems now, when patients are coming when employees are coming to the hospital to work for their shift, they're checking their temperature to make sure that they don't have a low-grade fever, and obviously they're assessing them for any cough, but they're also asking them about any loss of sense of smell or taste, because that seems to show up pretty early in the course of symptoms of illness when patients that actually develop those symptoms. But sometimes diarrhea, sometimes nausea, sometimes sore throat. You see kind of a wide range. And a lot of patients don't have any symptoms at all. We know from some of the studies that are being published now that anywhere from about 20% to as high as 50% of patients we think actually could be completely asymptomatic but still be contagious and carrying the virus. What's so difficult with this particular virus is the usual onset of symptoms from when someone becomes infected. The average time is 5.1 days. So in that 5+ day period, that person could still be feeling well and going out and being around other people, but actually be contagious and spreading the illness. So that's a lot longer time than what we usually would see with the flu, which is just a few days. And with the flu, when people get the flu, usually you get fevers and body aches and headaches and cough, and it all comes on very quickly. And so those people know to stay home. With this one, we're still learning more and more about what symptoms are concerning, but some of the things like the fever and the cough, show up kind of at gradual stages over the course of illness, which just makes it, one, more difficult to determine who needs to be tested and who doesn't, but also makes it more difficult for people because they say, well, I've got a little bit of a scratchy throat and a cough and I feel fatigued, but I think it's just a cold. I'm still going to go to work. With the limitations on testing, we have to be very choosy about who we do test and who we don't. We talked about the virtual visits earlier. There are several patients that I'll have that are low risk, don't have other medical issues, but they have the typical symptoms, and so we just tell them, let's just assume that you have COVID-19. We want you just to essentially shelter in place, quarantine yourself, and just let the symptom or the illness run its course. So really the testing that we're doing is predominantly for people who are high risk for complications. Obviously, people that are at the hospital or at the emergency room, we want to make sure that we're getting those people tested pretty quickly, because it's going to make a big difference on where in the hospital they need to go, what kind of protective equipment they need to have for those that are taking care of them. But that's pretty much it. So we're really the numbers that we're seeing of positive cases is just a fraction of the actual cases that are out there, which is again scary when you see exactly how many people have tested positive already. Essentially, you can probably triple that number, if not more, because of those patients that we aren't testing, that we have a pretty high suspicion that they are positive.
So I think in general, the best thing to do if you feel like you're starting to have symptoms, cough, fever, sore throat, really any of the symptoms and you're concerned, the first thing to do is to call your doctor's office and talk to them, because I would say pretty much all of the outpatient centers now are going to have sort of a screening questionnaire to go through to determine whether you meet criteria and you need to be tested or not. And to help you better understand what your risk is and where you should go, if anywhere. The majority of people, especially healthy folks who have this, the best thing to do is going to be to shelter in place, to isolate yourself, to self-quarantine. You can use things like Tylenol for fevers. I mean, you can treat yourself similar to how you would with another virus. The The concerning part is going to be if you start to feel like you're having a lot of shortness of breath and breathing problems. This is where most of the patients that are having complications, it's because of breathing. So if you're having shortness of breath or breathing problems, that's the time you really want to go to the emergency department. Otherwise, you really want to try to avoid the emergency department or even going to the office, because there isn't a great treatment that's going to fix this. And your likelihood of exposing other people to this virus is very high.
And to the same point, we're talking about, it has a lot of similar features to other viruses. It might not be coronavirus. And so then if you go straight to your doctor's office without calling first, you go straight to the emergency room, if you end up testing negative, you potentially have been exposed to the virus now in those settings, thereby perpetuating the spread of this virus.
So, I guess the good news is that the virus can't spread if it doesn't have an opportunity to move to a new host. And that's where this concept of social distancing has come into play. Because if you don't have contact with someone who has the virus, you can't get it. It can't just float around. So the reason that it's so important for people to stay home and have very limited contact with the outside world is because that makes the virus go away. When we look at places where strict social distancing has been in place, their infection rate is drastically different than places where it isn't. When we look at places like Italy, even in the United States, places like New York, where that social distancing was not put into place right away, that's where we see this huge uptick in cases. But in places like Germany and Japan, where social distancing and sheltering in place has really been very, very strictly enforced, their infection rates are much, much lower. And because of that, they have the supplies that they need. They have the medical equipment that they need. And that's the good news, is that if we can follow those guidelines and follow their example, we really can drastically slow the spread of this virus. Even in China, where they really had it really blew up there for a while. Now they universally have had very strict precautions in place for quite some time, and they've gotten it under control. I mean, people are still going to get sick, but at a much more controllable rate. And then the benefit of that is that it allows time to come up with treatments. It allows time for the medical equipment to be in place, and it allows time for the medical community to be prepared to treat those patients. So that's how social distancing works. Herd immunity is something that is seen in a lot of illnesses where we're able to vaccinate, or people have had those illnesses, so your body becomes immune. And once a large majority of the population in any area is immune to an illness or has the antibodies to an illness, they no longer get sick. And because all of those people aren't getting sick, they're able to protect the people who aren't immune, because there's no virus around or no illness to spread. So that those people who are immunocompromised or don't have the immunity for whatever reason to that illness aren't going to get it, because it's not being spread around. And unfortunately, that just isn't in place right now with this new coronavirus, because no one has any immunity to it, which is why it has spread so quickly.
Yeah, it's a little different than the flu. So with the flu, seasonal flus, it's there every single year. So many people are getting sick every year with the flu. They actually develop a little bit of an immunity from that standpoint. And then with vaccines, you can develop herd immunity. So we just don't have those things. With this being a brand new coronavirus, a novel coronavirus, no one has any immunity, even though some coronaviruses actually cause the common cold. This is just a brand new one, so our immunities to the cold don't really apply in this case. It's certainly too early to say now, because with this being new, we don't really know how it's going to react. But for a lot of viruses, they're less stable in hot and humid environments. Like I was saying earlier, it isn't really alive. It needs to be in in some other type of cell in order to continue to live or reproduce. It is stable though on surfaces, hard surfaces. So think doorknobs, phones, handrails, those sorts of things. And the virus tends to be, or a lot of times viruses are less stable in hot and humid environments, but that doesn't mean that they can't still spread. So usually when we see colds and flus decrease during the summer, it's more because kids aren't in school. We're not spending as much as our time cooped up because we like to be outside and enjoy the nice warm weather. So, with the social distancing measures that we have in place in most states, it's required, and with that means that schools are either closed or they've switched to online school. We're already creating what we would have during our usual summer, and we're still seeing the spread. So it doesn't make us very optimistic at all that just the warm weather alone is going to be enough to prevent this from continuing to go. And even if it did, it's sort of like we saw in 2009 with the H1N1 pandemic. It really picked up in the late spring and early part of the summer. It finally settled down a little bit towards the end of the summer when school got out. But then as soon as school started back again in the fall, we had a second spike. So even if it did calm down a little bit, that's probably what we're looking at again with this coronavirus. Vaccines, I think, is ultimately what's going to really slow this down, because we don't want everyone to get sick and develop immunity in that regard. We'd like to really kind of slow this down with the social distancing and essentially allow us more time to develop vaccines and good treatments so that we can minimize the number of people that are hospitalized and die from this. But I mean, realistically, a vaccine has to go through safety studies before it can be mass produced and given to large numbers of people. So if it were a year from now that we were doing vaccines, I would be shocked. I think even with in the U.S., the FDA accelerating this, and with the World Health Organization's help at accelerating this, we're looking at probably 18 months from now before we're able to start giving vaccines. And then usually, the same was true with H1N1 flu again, but with that one, essentially, they just had to develop a different flu vaccine. It was not start from the very beginning and do all the safety research. It was just we identified what type of flu it is. Let's make the new vaccine. But there's production delays. It takes a long time to produce those vaccines, and so usually, what we'll do with those sorts of things is we'll give the vaccines first to the people with the most underlying chronic conditions, so people who are at the highest risk of complication from whatever the illness is at the time, and healthcare workers. And so, we're looking at maybe 2 years before we can get everyone the vaccine. As far as treatments, there's a lot of stuff that's being looked at right now. Of course, there's a lot of different antivirals that we have for other types of viral infections that are being tested. Some haven't really shown any promise at all. Some maybe showing some potential promise. There's other things you see about hydroxychloroquine, which is a medication that's used for rheumatoid conditions like rheumatoid arthritis or lupus as being a potential treatment. Chloroquine, which is a medication that we would use to treat malaria as a potential treatment. Azithromycin is being used in combination with those two things. It's actually an antibiotic that we use for respiratory illnesses. So those things are being looked at, and I know that there's been some anecdotal evidence that they potentially could work when we look at Italy, where they had been using this for some of their most sick patients. But we don't really have any good data yet to say, yes, these are absolutely going to be the treatments. And that's kind of the problem early on, is anecdotal treatment. There's a lot of reporting bias that could occur. If you're giving it to people who would otherwise recover anyways, then you're going to get good outcomes. If it's you're giving it only to the sickest of the sick who are less likely to recover, then you're going to get poor outcomes. And so what you really need to do is give it to varying different groups of people, see who it works best for, who it doesn't, and you essentially have to compare it to just standard treatment, which in this case is just supportive treatment. So, we've got a long ways to go, definitely for the vaccine, but for treatments, at this point, it's kind of a hope, and maybe this will work, but we've got, probably months before we really have any really good understanding of what is a good treatment that's going to help reduce severity of illness or prevent death.
Thank you so much, guys. Thanks for taking time. I
Sure.
appreciate it.
Yeah.